All right, everybody, I think we'll go ahead and make a start. Thank you for coming this evening. This is our first presentation for the Design Research Seminar Series, and we're really excited to have this one be in person. So thank you to Lawrence for coming all the way from Northern Ireland. So today we're going to have Professor Lawrence Taggart talking to us about supporting acute hospitals to maximize the implementation of the Oliver McGowan Learning Disability and Autism Training using a systems approach. Lawrence is a learning disability nurse and a professor at Ulster University, so if you'll all join me in welcoming him. Yeah.
It's great to be able to speak in person and see people in 3D rather than just behind screens, so thank you very, very much. And thank you for the TISR team for giving me this invite. So as Susie said, I'm a learning disability nurse and a psychologist. I work at Ulster University in Belfast, and over the last number of years I've been very interested around developing interventions and testing within community settings or hospital settings. But one of the things that we've found when you undertake research is the difficulties implementing it. Because it's a big research. I would always say research is easy, but the implementations got harder over the number of years. And I think there's a lot of issues with trusts in relation to capacity and capability, particularly post-COVID as well. So very interested in the Oliver McGowan. I was part of the consultancy with the NTDI and Anna Marriott's team, so I'm very much aware of the pilot study and how the 4 different sites came about. So part of that consultancy that I was part of, we decided that we would do a Delphi study. So a Delphi study is where if there's not enough information in the literature, we would try and access experts to try and bring some of this information together. So that's what the talk's going to be about today. So I'm going to talk for about 40 minutes. Susie's going to keep me the time, and then we're going to have some questions and answers. I'm not a clinician anymore, so looking for a bit of debate, looking for a bit of challenge, looking for a fight, looking to keep this interested, okay? So please don't hold back for the questions and answers. So did I just use is there a clicker or is it just?
You can just go through your meeting.
Oh, I can use this. I can bring, oh no, I can't actually.
I think you might be able to go through just like
Okay,
that.
okay. So what do we know? Well, we know that people with learning disability and autistic people, we know they're more likely to die younger, and they're more likely to die of avoidable deaths. And there's been lots of research, lots of research in the literature to suggest that you know in hospital that they also have this difficulty as well. We also know that people with learning disabilities and autistic people have poor physical and mental health as well compared to the general population, and they have poorer quality of life. And some of these inequalities and these equities, they're around not being able to access appropriate responsive services. There's failures to make individualised adjustments, the usual pathways for the provision of care, for treatment and support. And there's also been some research coming up, and this is why there's the Oliver McGowan Learning Disability and Autism Training around within acute hospital sector, and probably within mainstream mental health sector as well. Staff don't have enough knowledge, and they don't have enough, maybe more positive attitudes about what reasonable adjustments to put into practice. Okay? And we know that people with learning disabilities and autistic people, they have high healthcare costs. Okay, for a small population, they've unmet need, and they've preventable health disparities. So we know if we do something, we could improve the health of people with learning disabilities, and hopefully that will reduce some of the costs within the NHS. So I can only speak about Northern Ireland. I'm from Belfast. People with learning disabilities are about 1% of the population, maybe less because they may not be always recorded. But our spend on the NHS is about 78%, 7 or 8%. That's a huge spend on a very small population. I'd be happy to take photographs. If I had known, I would have got my hair done. So we also know that acute hospitals often struggle to make individualised adjustments to usual pathways for the provision of care, treatment and support of both these populations. And there's growing evidence to suggest that there is a lack of knowledge and there's a lack of skills concerning people with learning disabilities and autistic people amongst the acute hospital staff. And Pauline Hislop has been doing a number of work we all know of, but there's been a really, really good systematic review done by, I don't know if it's Maria Maloney, but they're in the University of Limerick, and they've done a good systematic review around looking at the literature and around acute hospital staff and what they know about people with learning disabilities and autism. So research clearly suggests that there's a fundamental need for the learning disability and autism awareness training. So we definitely know that, and we know how and why. So just in case you don't know, there's been a number of terrible, terrible sad cases where young people with learning disabilities have died horrific deaths, and have died deaths that could have been avoided. Okay? And that's how, and obviously we can see the picture here of Oliver McGowan and Laura Booth and Richard Hanley. So these are, sad to say, those are good cases to raise because they put it in the public format. They put it up there in public health, and that's how Paul McGowan has got this raised at such a high level. And it's really, really good to see the Department of Health reacting to that, and how then the Oliver McGowan learning disability and autism training is mandatory within England. It's not mandatory anywhere else, it's just in England. So that's good. That's a good thing that's come out. Okay, so I do want to share one wee clip. You've probably seen this. That's it. So I have no glasses on.
I think if you just click on the video, it should be okay. There you go.
He saw the good in everything. He embraced life. He really loved life. And life seemed to love him.
Teenager Oliver McGowan died 4 years ago. He lived with epilepsy, mild autism and learning disabilities. He also maintained a very active life. Oliver died after being prescribed antipsychotic drugs in hospital when being treated for seizures. This was despite Oliver and his parents repeatedly informing doctors that he should not receive the medication. Today, an independent review into the care Oliver received at Southmead Hospital in Bristol found that his death was potentially avoidable.
Positive to have it formally acknowledged because it's what we always knew. Clearly what it just confirms to us is Oliver's death was avoidable, and we knew that, and it was wrong. You know, when Oliver was in intensive care and we used to drive home every night, I used to say to Paul, this is wrong, it shouldn't have happened. We told them not to give him a drug, they did, they ignored us. You know, there's so many things about this which is wrong.
The Learning Disability Mortality Review made the point that staff failed to properly assess Oliver when he arrived. Tom and Paula see this as especially important, as an inquest 2 years ago said the doctor's decision to administer the drug was appropriate. They now want a fresh inquest. The charity MenCap report that 1,200 people with learning disabilities die avoidable deaths each year. They say for too long the vulnerable haven't been heard.
Sometimes it's just simple things that could make all the difference. It's taking a bit of extra time to explain something, it's taking a little bit of extra time to diagnose somebody and taking into account their condition and treating them as individuals. So this report is really important because it's saying very loudly and very clearly, people must be listened to.
In response to the findings, North Bristol NHS Trust said the staff who cared for Oliver did their very best in managing his complex needs as his health was deteriorating. We're committed to continue learning and will act on this report. A police investigation is continuing into Oliver's death. Now his parents want his short life to be in better care for others with learning disabilities. Warren Nettleford, 5 News.
Obviously that was taken a couple of years ago. I just can stop that camera. Sorry, oh, I can just close that down. Okay. Okay. Okay, so as part of that process was going on with Oliver McGowan, the Health Education in England recommended training for acute hospital staff, and I'm sure you've seen the document, Learning Disabilities Core Skills, Education and Training Framework. It's out there, and there's 3 levels of training: Tier 1, Tier 2 and Tier 3. So Tier 1 was for those staff who would have occasional contact, Tier 2 more regular contact, and Tier 3 providing directly. And the Oliver McGowan training is geared at the level 1, the tier 1 training for those staff, you know, who wouldn't have a lot of regular contact, but just in case they come into people with learning. So that's where it's tier 1. And it wanted to focus around application, applying the knowledge. It wanted to focus around demonstrating an understanding of what it's like to have a learning disability and the health needs. And it's also about how do you apply that knowledge. So that's the whole point of this 3-hour education programme. Okay. But in the middle of all that, there has been a very, very, very good report published by Marriott and Hartfett in 2020. And they looked at studies that have tried to develop learning disability and autism training for a hospital staff. And they found there was 20 studies. And in reviewing those 20 studies, they found that yes, that acute awareness training, that level of learning disability and autism awareness training did increase staff knowledge. It did increase or change staff's attitudes, and it had some increase in people's confidence to work with people with learning disabilities and autism. But as part of that review of the studies, they also found that none of the studies had evaluated the long-term impact of the training on the care and treatment of people with a learning disability accessing primary and acute hospitals. So we really don't know. We had 20 studies, developed training, evaluated them, a lot of them maybe not robustly done, but we don't know from those 20 studies had it had any direct impact on people with learning disabilities. Many of the studies did not identify what worked. So what is it? What part of that training programme worked? But more importantly, what didn't work? Okay? And this is to be critically contrasted with the recent avoidable deaths of Oliver McGowan, Richard Handley, Laura Booth, and not only within the UK, but hundreds. And in that video, they said about 120 deaths in the last couple of years. So we need to think about that study, what that information is saying is, and we need to sort of look at, you know, what does frontline staff need to actually change the clinical care of people with learning disability in acute hospitals, and what can change or what can diminish the number of deaths. So again, we'll go back to that study by Maloney and the University of Limerick, and they did an international scoping review, and they found that there was a lack of research on the implementation of reasonable adjustments in acute hospital settings for children and adults with a learning disability, and that was unfair. Just they weren't getting access to the appropriate services and when they needed it. And we also just recently published a paper on what I'm going to talk about on this Delphi study. And we also found that we think it's maybe unrealistic. We think the Oliver McGowan training is a bit unrealistic to believe that all the acute staff across England who get the Oliver McGowan mandatory learning disability and autism training, we're not sure if it by itself will lead to changes in clinical care. I think there's other things have to be put in place. So we argue that conventional approaches to learning disability and autism awareness training programs in primary health care and acute hospitals will continue to make minimal differences to the care provided to this population. And we also think that the outcomes that people with learning disabilities will experience, there'll not be much differences. So it's quite a controversial statement to make into such a big programme that's going to be implemented across England at a huge cost for staff and resources and finance. So I hope this isn't going to be in the Sun or the Daily Mirror or nothing like that. Okay, so if we are to improve the quality of healthcare provision and reduce avoidable deaths of people with learning disabilities and autistic people, there needs to be a fundamental review and reformulation of training approaches. So we set out to undertake this Delphi study to look at this. So we wanted to set out two key questions. The first one was around, if you're going to develop a training programme, what do you need to be in it? Because in the Oliver McGowan training, the pilot study, there was 4 groups of people, 4 organisations was asked to deliver that training, but the 4 groups delivered had different content and different delivery styles and at different lengths of delivery. So we wanted to know, what would be the content? If you were going to deliver a learning disability or an autistic awareness program, what would be the content? What would be the delivery mode? What would be the duration? And what would be the resources? Now, that's probably something similar the Oliver McGowan training set up to do. We know that. But we wanted to take it a step to the next step. And we wanted to know, what does these organisations, those hospitals, what do the hospitals need to make sure the Oliver McGowan training is implemented, or any form of learning disability and awareness training? What do they need to do? What does the organisation, this big complex system, what do they need to know and what do they need to do to ensure all these frontline staff members can put in that training? So we call that systems-related impact indicators or facilitators, and we're going to use a logic model. We'll talk about that later. But these were the actions. These are basically what actions does the hospital need to do to maximise the potential implementation of the learning points for the awareness training. So stay with me. So a wee bit of technical stuff here. Okay. First is a Delphi study. It's a 2-round Delphi study. We use Qualtrics. We identified 69. We just did a study. We found the authors of some big papers. We also wrote to some really good clinicians as well. We included all health and social care departments in the UK. We went to IASAD, which is the International Association for the Scientific Study of Intellectual and Developmental Disabilities, and that basically was just to get us a group of international academics, clinicians. Okay. We also wrote to the American Association for Medical Doctors and Dentists, and we wrote to Special Olympics International, who again had this massive international reach. 69 professionals indicated that they would take part, and by the end of the study, 57 had stayed in the second round. So the way we did it was, the first sort of round was, we identified a number of items around training and impact. We presented them, and then we sent them out to these 69 professionals, and then they rated them on the importance of, this is really, really important. We were looking for what's called a consensus agreement. So normally in a Delphi study, most people take 70%. You have to get 70% agreement before you can put an item in. And then we had ethical approval from the University of Ulster. So, like you're saying, we created 65 items, and there was a pool of us. So there was the people in the NTDI, and we had people with learning disabilities, we had family carers, and we had healthcare professionals as well. So we identified 65 items around what would be the aims, the design, the content, the delivery, and we identified 31 systems indicators or impact indicators around resources, outputs and outcomes. So how would you know it's working? And like you're saying, we sent them round, first round, we got agreement. If it was less than 70%, the item was kicked out. If it was in, it would go back out, and then it was sent around a second time, and those items were reduced. Okay, that's the technical, boring bit of the lecture. Over. Okay, so, and when you think about systems, sorry, this is the next technical, boring bit of the lecture. When you think about systems, it was really unrealistic to think that any learning disability and awareness training by itself would ever change practice. Very, very unrealistic. By itself alone, to have any sustainable impact, and not only, well, we know it can change staff's knowledge, attitudes and confidence, but more importantly, changing clinical practice. And that's what we want to know. How can we support staff? How can those organisations really help staff to change the care of people with learning disabilities and hopefully reduce the number of complaints, the bad practice and the avoidable deaths? So the framework we used was Pawson and Tilley's realism review. I don't know if you've heard of it. And it was all about looking at the context, the mechanisms and the outcomes of what works from whom and at what circumstances. So this study goes beyond what works to ask, what is it about a learning disability and autism awareness training program that works for whom, in what circumstances, in what respects, over which duration. So it was really going into that deeper systems level. Now that's it. Boring part of the lecture is over. Now we're going to get into the nitty-gritty. So we asked a number of items, and the number of items were around what would the training content be. So these 57 participants from around the world said that the 100% of the participants said the training needs to make sure that the reasonable adjustments that are needed for people with learning disability and autistic people are put into place. It needs to improve training participants' communication. The training, 97% of participants said that it presents behaviours as a response. So when people with learning disabilities present in a certain way, behaviours that challenge, it's a response. It's a response to maybe not being able to communicate, or it's a response to maybe pain. The training had to promote positive interactions, and the participants, the acute hospital staff, had to increase their understanding of the physical and mental health needs of both of these populations. And again, they need to be able to identify people with learners. So all these, as you can see on the board, I mean, they really are reaching top significance here. So they need to be included. If you're going to develop a training program, that's some of your outcomes. So what about the design? Again, this content. Again, it needs to be designed in partnership with people with learning disability and autism. It needs to be designed with their family carers and paid staff, and it needs to be designed with healthcare professionals from the acute hospitals. The awareness training should identify and target specific behaviours that people may display, and not only looking at one setting, but across the hospital spectrum, like A&E, outpatients, inpatients, and so on, and within ambulance services as well. And it was really interesting, again, 9 out of 10 people said, this is good, we need this, but we think there should also be bespoke training to the next stage. That's that tier 2. Okay, so that was good that they were saying that as well. So if we look at what should we cover, okay, what should we cover in the training? The first thing they were saying was nearly 100% of staff were saying we should look at that whole topic of diagnostic overshadowing. The second thing is we should try and explain how people with learning disability and autism will have fear and anxiety coming into this strange setting, particularly when they're unwell and there's lights and noises and tons of people and having to wait. The training should actually look at how can we manage behaviours that challenge. I just want to apologise for my spelling mistakes. I do have dyslexia, just want to say that. I've noticed it last night, and then I don't know how to change it when you've got these things made. Okay? It should highlight also premature deaths of people with learning disability, nutrition and hydration, constipation, dysphagia, epilepsy, respiratory and postural care. And most of these, again, as you can see, they're going from nearly 98% down to just over 75%. So these are key components that needs to be in that disability training. Now, what about the delivery style? Again, 95% were saying training for all frontline staff. That's that tier 1. It should include videos of positive experiences of people with learning disability in a hospital setting, and not just focus on the negative. They also think that, again, nearly 100% are saying it should be mandatory. And again, a small group of people, about 75% of people, but still over that 70% threshold, highlighted that the training needs to be adapted for different groups of staff in different settings. So maybe in surgery, they need a different form of training compared to maybe A&E or different types of clinics. What was interesting, I hope you like that colour, what interesting was that the panel couldn't come to a consensus around should it be face-to-face, should it be e-learning, should it be delivery only, should it be online. We couldn't get above a 70% threshold, so we couldn't make any recommendations. And also we couldn't recognise how long it should be. You know, should it be 3 hours? Should it be a day? Should it be 1 hour? We give everybody the option, but we had no 70% consensus. Look, even though we sent it round a second time, we said that they still couldn't get the 70%. So we're still not 100% sure the way it should be delivered. Now, that's the training, as in the actual learning disability and autistic training. Now we want to move into the systems. What would help a hospital to ensure that the staff who get this training would put into practice this training? So some of these systems indicators included, and again, all of these reach 70%. Okay? So hospitals, oh, I wish I could remove that little. That's okay, I'll try and work it out. So yeah, over nearly 100% of people said that people with learning disability and autistic people, if they're coming in for a planned visit, they should have a pre-planned visit. They should come along before the actual visit. There should, every department would have user-friendly information leaflets. Every hospital should employ an acute liaison nurse. Everybody should be using where possible hospital passports. Very interesting what they said was, if you're going to change anything within hospitals, it has to be within policy. So again, that figure's sitting around nearly 90%. 85% of all the participants said, get it changed within policy first. Make sure that's a key priority. Okay? And again, even though you may have one overall liaison nurse, but each department needs to have a learning disability and an autism champion. My mother's got dementia. When she goes into the acute hospital, they have a little purple ribbon in Belfast, and that's the sign that that person has dementia. And then there's the nurse on the ward who's a dementia champion. You can speak to her. Very effective. There's always one on a shift, so in case they're off or whatever. Again, not as high. So what was that figure? About 75% of people are saying that everybody with a learning disability and autism should have automatically tagged on their records when a person comes in that they have a diagnosis. Now, that's a bit controversial. Some people may not want that. Maybe people should be given the choices. Some of the, again, it reached over 70%. Some people thought about having a social marketing campaign within the hospital to promote disability awareness. And then the last was, some people thought about using virtual reality to diminish, particularly people with anxiety, coming in. So actually having that technological resources within the hospital, maybe having a person has an experience of walking through a hospital, their journey through the hospital, they could see what it is, they can see the ward. We actually have a PhD student who's actually looking at children with autism in primary school, and then how do they transition to secondary school using virtual reality. So we're testing that out at the minute. So if you were to put this training into place, if you were to implement those systems indicators, and we know it's not just going to happen overnight, what would that look like? What would be the outcome of that? And how would you know it's working? So again, we asked our 69 participants, what would that look like? And what they said was, the hospitals need to monitor the complaints and respond appropriately. And hopefully, if we implement that, this should diminish. Likewise, critical incidents. The number of critical instances within hospital, they should diminish over the first year or so. Regularly, you should get feedback from people with learning disability and autistic people and their family carers about what was your journey like. Again, the learning disability and autism training needs to be evaluated annually, and all hospitals should have a record of all the people who attended. That's what should happen in about a year. And then within about 3 to 5 years, what you should, this is what these international professionals and academics and clinicians all said, they said that the numbers and reasons for death should be reviewed, and you would expect that to get lower. Hospitals should develop further learning disability and autism training. That's this tier 2. Everybody should have tier 1, and now we should be moving into tier 2. You would hope to see a reduction in hospital admissions and readmissions because people are getting better care. And lastly, again, there should be a reduction in appointment non-attendance. So the fact that if people have to come back to hospital, they've had such a positive experience, they'll attend. And then what's called outputs from a systems perspective. So this is a little bit controversial. You could see everybody thought that if you put all these systems indicators into place, there should be a reduction in avoidable deaths for people with learning disability and autism. So the whole aim of the training is to reduce the number of people who die and die of avoidable diseases. Now, we struggled to get consensus on these items. And the reason why I'm putting them in, because I think there's a reason for it, because a number of the people are from outside of a Western country. They'll be from low to middle income countries as well. So, but I'm keeping them in because I think it's interesting. Some of the systems in, because there could be a reduction in hospital admissions, and if there is an admission, the period of time could be smaller. There could be a reduction in A&E, and more importantly then is there could be savings within the NHS. So for a small amount of money, well, it's not small, like putting in the Oliver McGowan train is going to be very, very costly, but that could lead, that input, that cost, could actually have bigger reductions in the long term. Roy McConkie and I did some work with Special Olympics a few years ago, looking at logic modelling systems, and Special Olympics International called that a tipping point, when all your hard work, all that research has been done, at some point it just becomes part of natural practice. So people just make those reasonable adjustments, those systems indicators, as part of natural, normal practice. Okay, we're not naive. We're absolutely not naive. We know what the NHS is about. We know the issues around COVID. We know the issues around capacity. We know the issues around capability. We know the issues around financial resources and staff turnover. So we got these professionals to indicate what would be the barriers to implementing the learning disability and autism training. So the first is around a lack of clear guidelines. This goes back to your policy. A lack of resources and technology on the ward, the information. A lack of understanding the role of carers. Now, that was the first time that came up. But the staff did see a significant role for family carers, but not maybe the best being utilised. Significant staff turnover, therefore losing trained staff. A negative culture of hospital and managers, not identifying learning disability as a priority. We're doing a big RCT at the minute, and we're working with a number of learning disability organisations, and one of the managers says, I don't see how could people with learning disabilities undertake a randomised controlled trial? You just couldn't get it. A negative aspect. Learning disability and autism not identified as a priority. That goes back to that policy. If you get that in policy, if you get that as a priority, and there's key outcomes have to be put up, finances rings, people got jobs, it will make a big difference. Again, some staff may not have regular contact, maybe in certain wards like your kidney disease, you may not see a lot of people. Again, staff busy, short staff shortages, and not all staff receive the disability training. So we're coming to an end, which is good for you. They have 10 minutes, okay, but I have 10 more minutes worth of slide. So like we're saying, we used a modified Delphi survey, an international panel. We had reached our 70% agreement, and we've got information around aims, design and content. There was variations of opinion were found about the training. We didn't get agreement around delivery way and the length of delivery. We did identify a range of systems-related impact indicators for the hospital, and they were agreed upon in relation to resources, inputs and outcomes, and how they could be implemented within an acute hospital. And the expert panel did identify and agree on 7 barriers, okay? So the training content and the systems-related impact indicators of the learning disability and the autism awareness training could also be applied to other cognitive disability groups, like people with dementia, people who have had a stroke, people whose maybe language is limited. So we do think, and if you look at cognitive disability, that's 15% of your population. So if you get it right for people with learning disability, you're going to get it right for a lot more people. Okay? And that should improve the equity of healthcare provision. And whilst this study is prospectively identified the training content and system-related indicators based upon literature and expert opinion, we have no idea it works. I have no idea if this is going to work or not. So we need funding now to go into a few hospitals at the systems level. And we need to go and get another couple of hospitals who we do nothing with. And we need to go and change the systems, put in the policy, put in all these systems, deliver more training, and then we need to see a few years down the line, and it could take 10 years, are people, as the number of deaths being avoided and as the complaints reducing. But that's what we need to do now. We need to test its effectiveness. So just one more thought before I go. So if program designers focus on training content only, they will fail. If you just deliver training by itself, you will fail. It will have no impact. So therefore, you need to think of the context and the awareness, where the awareness training is to be delivered. You need to think of the mechanisms of the behaviour change, and you need to think about the outcomes of the programme, not only for the person with learning disability, for the system. And there's growing evidence to highlight that disability awareness training programmes themselves are not complex, and it isn't. You know, a training programme by itself is not difficult to do. It's the system. It's the hospital. It's so complex. That's where the challenge is. Therefore, greater emphasis should be placed not just on what to include, but also how to implement these disability awareness programmes in complex acute hospitals to maximise their full potential. And I think that's where we need to take this. We need to now take, you've got the Oliver McGowan training, now we need to look at what systems indicators do we need to put in to maximise that training. So coming to the end, but this is the exciting part, like a good psychological thriller. So how can we support acute hospitals to maximise the implementation of the Oliver McGowan learning disability and autism training? Well, if you're going to do any implementation stuff, you need to have co-production at the very top. You need to bring your stakeholders together. And I don't mean people with learning disabilities and family carers. You need to bring also senior management, people who can change policy, people who can ring-fence budgets, people who can make job descriptions and advertise for posts. They need to be part of that co-production, as well as people with learning disabilities and family carers. We need to think of the complexity of hospitals, and then at the very top we need to have this ecological thoughts, because don't forget, in the bottom circle is the individual, but look at everybody else around that. So it's to do with the nurses, the reception staff, the porters, the allied health professionals, the doctors, in those, I know it said schools up there, but just think within that complex of hospitals and the finance department, the health and safety department, all those people need to be brought and thought about. And again, this is, if we're going to do any evaluation, we use the Medical Research Council. But just recently, in their recent guidelines of 2021, they have brought in the core elements, the context. They want to, if you're going to do any form of intervention, you must contextualise where that intervention is going to be developed or implemented in. So talking about considering context, defining, refining the programme theory, engaging in your stakeholders, and so on, and the economic interests. So one way to do that, to the crunch of this big cliffhanger, one way we're going to do that would be to use a logic model. Has anybody heard of a logic model? Yay! So there's lots of people, it's becoming a thing more popular now. So a logical model is just a physical diagram of how to implement research into practice. At the very heart of it's about co-production and co-development. The next is around understanding the context and this complex system where we're going to implement the Oliver McGowan training. It clearly identifies what inputs and resources you need, and also it identifies the outcomes that needs to be put into place, as well as what would be the outcomes over a time period. Now I know this is very quick, but this would be what a logic model is based upon our Delphi study around the Oliver McGowan training. So at the very top you see context. So it's trying to ask, does the organisation understand why you would ever want to implement the Oliver McGowan learning disability and autism training? Or is it just a tick box exercise? Because if it's a tick box exercise, that could be easily done. But if you really want to have maximum impact, you need to think about the context. And you also have to ask, is the organisation ready to change? And that's, Sissy, the CICI framework will help an organisation to reflect upon what is the problem And what is the problem if we don't do anything? Okay? Because if you don't do anything, we'll still see the number of deaths. Nothing will change. And we'll still have it all on the TV. And then it will help you to identify, well, what inputs is required? Those systems indicators that I've just shared with you. These would be some of the more recognised good indicators from this study. What would be the outcomes? But particularly then, what are the outcomes? The outcomes for the adults with learning disabilities and their family carers, the outcomes for family carers and healthcare staff, and then more importantly, what an organisation likes to hear, what will be the outcome for me as a system for an acute hospital? Because if you go and do something new, there's a cost. So an organisation has to know, this is going to cost me X, Y, and Z, but I know in the long term there's going to be benefits. Not only benefits for the person with learning disability, like quality of life, better journeys, less incidents, less deaths, hopefully. But there's also going to be a saving for the hospital somewhere along the line. And it's that you would do if you're trying to maximise the Oliver McGowan and the Oliver McGowan Learning Disability and Autism Training. So I think we're just going to just a couple of references. I'm going to leave the logic model up. I think I've done my time, and we're going to have some questions.
Thank you, Lauren. So does anybody have any questions for Lawrence to get us started off?
I think more of some feedback than a question, really, if I may. So I work for a service that supports the reduction of Tier 4 mental health detainments for young people with learning disabilities and autism, and we work hugely with infant wards, as you would imagine. So actually, we've all done and implemented the Oliver McGowan training throughout our kind of areas. However, there does need a better model. It does need to be consistent. So I'm really keen to see this develop. So thank you.
You're welcome. Thank you.
Anybody else? Questions, comments?
Thank you. Thank you very much for that. It's so stimulating and really quite provocative in a very nice way. Thank you. I'm a senior lecturer at the medical school here, and as I think you may know from one of my colleagues earlier on, we offer our students in their second year of their 5-year programme a 3-hour workshop on learning disability, which is delivered in collaboration with people with learning disabilities. We had to fight very hard to shoe that into the 5-year curriculum, which is so well stuffed and so inflexible. We've had positive feedback on it, but I'm just wondering, I don't think you asked your participants about regularity of training or updating in any way. I'm very concerned that we're giving people a very memorable experience, perhaps for 12 months or something like that, and I'm not quite sure what happens.
So yeah, we asked how often should the training be, but we didn't get consensus. We give 1 year, 3 years, 5 years, but only the 3 years and the 5 year they couldn't recommend. And I agree, that's where I think Tier 2 really comes in. I think everybody should mandatory should get it. And I think it's right that they do get stage 1, Tier 1, but then I think we need to take it up to Tier 2 and Tier 3. And again, it's also saying, we have a medical school in Ulster University in Derry, and we're trying to get some learning disability input. Again, strong opposition, you get a little bit of time and it's not really enough. But I think that's why I liked what Special Olympics done, because Special Olympics does a lot of the health screening, and they have a lot of health. They have 7 different health stations from doctors and nurses and dentists and so on. And what they say is they're asking the question, because they get $25 million a year to do all this from a charity, and they're asking the question, how do we know it's having any impact upon their clinical practice? And that's why they're hoping maybe around about 10 years. It's not a big effort anymore. It just naturally happens, and they call it a tipping point. So really you're doing yourself out of a job. That's what you want to do. So it just becomes part of natural practice.
And I also think, as we're moving into, a learning disability or autistic person that's moving into adulthood, I still think there needs to be that co-production with parents. And I think you'll find some of the cases that you've referred to today has been the lack of joined up working with the parents, so I think you know, we would like to see some form of checklist that's done in with that kind of pre-admission process that is done with parents and carers, is that, you know, even if that young person is over the age of 18 or 16.
I'm just going to go back to Jill and I'll pop back up to you.
Thanks, Lawrence. That was really interesting. I don't know whether it's a question or a comment. We live in really difficult times, don't we? Social care is really stretched, healthcare is really stretched. Just wondered, was there anything from your Delphi participants that talked about that context in terms of everything's really stretched, there's no funding, nobody's got any time, we have a workforce that is under-supported, underpaid, undertrained. Is it a backdrop against all those
in this Delphi study we didn't, but in one of our PhD students, I was talking to your students today, she went over to Chicago, got trained in a program called Health Matters, came back to Northern Ireland. We thought we would do a bit of a randomised controlled trial. We got 60 staff, 30 got trained. These were staff from supported living and residential, so they were healthcare staff, and 30 staff got randomised to the control group. The 30 staff got the training on Health Matters for 2 days, which was free and all the resources, and by a couple of weeks all the staff were saying that was lovely, but we can't deliver this. Because of the busyness of work, and because of staff shortages, and because it was never a priority. And that pure PhD student nearly had a heart attack because there was no PhD in that PhD student, but she went and she did a series of focus groups with all those staff, and that's what they brought. They brought up system-related indicators, and that took me on this journey around implementation science. So it's trying to, you know, like I can show you another logic model of positive behaviour support, because there was a big trial of positive behaviour support, 40 residential homes, 20 staff got the training, 20 staff didn't. It didn't work. So technically you could just say, what's the point of doing positive behaviour support? It doesn't work through a randomised control trial. But then they interviewed the 20 staff, 20 homes where the staff got trained, and all of them said, it's great training, we love the training, but we can't implement it because of how to run a home with staff shortages, and it's not a priority by staff. So the whole issue around implementation science is one of the biggest issues now. We can create interventions. But the hardest part is to implement them in practice. That's the challenge. You know? So it may be the best intervention in the world, but if you don't implement it the way it's meant to be implemented, you'll not see the change that you want to expect.
Yes, because I've got a learning thing, actually I've got myself lived experience now. I've been around for 22 years, and some people don't understand about how to co-produce a piece of work. They think, yes, I'm going to do this, but where's people live experience, where's carers, there's other people, so it's just, some people, they say they understand about how they need to co-produce stuff, but they actually don't understand how to use advocates or how to use carers. So it's just a minefield going, actually I've been told to you about co-producing stuff, so again, that's another issue. And also we're hoping to do the Oliver McGowan training, and also we've got partnership with different people who can support us to do the training. So again, so fingers crossed we can do the Oliver McGowan training, because we've got years of training staff here. As Kevin said, we helped her to do the midwife training. We're doing other support, having different work as well. So again, we've done on ground for years, and we have been supporting people to understand that you need to help people to learn experience, to help you to do the training. You can't do it on your own. You need to use different partnerships with different groups.
And I think it's not just the co-production, but the journey throughout the delivery of it as well, and to do that feedback.
Yes.
And I always say it's really good to identify what works, and this will tell you what works, but it's also really, really good to identify what parts don't work, so we can change it very quickly. The one thing that I don't have in here is the mechanisms of change, but I just thought it was a bit too complicated at this stage. So thank you for that comment. Daniel.
Hi Lawrence. Good to see you. I was just about to ask about the mechanisms. So you're talking about context and outcomes, and I've heard you talk about implementation science and so forth. I just wonder about that realist perspective about what is it, so what works for who and in what circumstances, and whether you got. I appreciate that it's a Delphi and therefore you're asking other people, but in the instances where you've implemented some stuff and tested some interventions out, what do you get as a sense as the important elements that need to be in the context to be and the mechanisms to be?
Very good question. So first of all, any logic model can only be developed in that specific context. So this would be a proposed logic model, but if you're going to implement that, that has to be implemented within a hospital, but then that logic model maybe has to be limited for a certain department as well, because you can't just generalize it all. The second thing, and just funny when you're talking about those mechanisms of change, the other big thing around implementation science is there's another big theory called normalization process theory, and I'm trying to work out where that comes in, and that's all around collectives. You know, the thing about mechanisms of change aren't measurable, and I've tried to just keep what's on the board. I think everything on the board's measurable and everything's really doable. Where mechanisms is, if you do this, things happen, sort of way, I don't know what the word unconscious, or it's very hard to explain. I'm still trying to get my head around it. But yeah, there are theories for the mechanisms and that greater implementation. But I think when you look at implementation sciences, there are lots of theories or frameworks, but like there's in nursing, they do the Paris framework. It's just about education, context, facilitation. There's QI as well, maybe not so much the evidence-based. But I do like a logic model because I think it's quite linear. I think it's quite easy to see how it works as well. And it's co-produced. I think it goes back to your point. It's co-produced by the right people. You have to have the right people. And it has to be co-produced really, really early, because then you get that understanding at the very top of the context. Because if you don't get people's awareness that there is a problem, nothing will change, and they'll not get that buy-in. I don't know if I've answered your question. Sound like a good politician.
Yeah.
Yeah, I just had finance. I just had a question about I think you mentioned in your Delphi that you didn't get consensus on how the training should be delivered, whether it was a mixture of face-to-face or online. Do you know what was decided on? Because I've seen different aspects where I work in the community where staff can take the online training, but it's not compulsory to then take face-to-face sort of consolidation.
Well, we were looking for
a format that people have to stay regulated to, or can they just do whatever they want?
I think, again, you know, we were asking as our consensus, we were looking for at least 70% plus, and we agreed on that. We didn't reach that, so we couldn't put it in. But I think it has to be contextualized to where you work. So if you work in a small department, it's probably just easier to do it face to face. If you work with a large department and a lot of people, hybrid may be better. You know, there's cost involved. There's who's going to train it as well, and if you're going to do it every year, now that gets into very costly and who pays. So there's lots of complications to think about. So I think, you know, when you develop a logic model, when you think about implementation science, you need to think about the context that this is going to be delivered in. And as I said earlier with Daniel's question, each one of those will be slightly different for each context. Like you're saying, you could do that with a school of medicine, you could do that with a supported living scheme, you could do that within a hospital. You know.
Oliver, thank you for your presentation. I'm more curious because I just listened to you talk about how you're already implementing the Oliver McGowan training. How many places across England are currently implementing?
Oh, okay, I can't answer. I'm from Northern Ireland, so I don't know. Any, do you implement it here in Kent? Is there anybody here from acute hospitals?
I don't actually know how we're actually implementing, but at the moment it's being rolled out. So I couldn't tell exactly because I am an Oliver McGowan trainer. So I was actually interested, so because the Oliver McGowan model has no option, it has to be face-to-face delivery. So you're thinking about something different if it was to be implemented. Because currently Oliver McGowan model is face-to-face only.
What I'm saying is we couldn't get a consensus among our panel to say what would be the preferred mode. I think it depends on the context. that delivery mode of face-to-face is a very resourceful implementation. And
But that's a requirement at the moment with the Oliver McGowan.
But it is a requirement.
For tier 2.
For not.
Oh, for tier 2, yeah.
For tier 1 it's online.
For tier 1 it's online.
But the tier 1 is actually just for front-facing staff, like who have very, very minimal. So the Oliver McGowan tier 2 is the one that's actually for like staff.
But if you roll that up across the whole of England, how many people is that? You know.
So in Kent, we worked out that it's going to be 123,000 people that are going to need to be trained in either in tier 1 or tier 2. Almost most of those tier 2. But that's a 7.5, 8 hour training.
So the argument that we're trying to make is, I think the figure for the whole of England is 3 million people. And I don't think the amount of cost that's going to take from a resource and a financial cost, I don't think it's not going to have the impact that you think it's going to have. And therefore I think it's ineffective. I'm only suggesting that, I don't know. We need to evaluate that, and we need to evaluate if we put the systems in.
What is the, so we've got the Health and Care Act, which obviously applies to Northern Ireland. What is the implication of your work and how the requirements of the Health and Care Act are interpreted in Northern Ireland? Okay.
I don't think we have that in Northern Ireland.
Does the Health and Care Act must apply across? Does it?
I'm not sure.
Anybody know?
Just delete that from the video. That'd be good. But I don't know.
I would imagine it's probably called something slightly different in
like
Northern Ireland. I'd imagine that it's similar, but just under a different title. I would.
I've tweeted that bit on.
Thanks.
Professor Taggart gets asked a question about health and care policy in Northern Ireland.
I just think, I think it's right. I think the Oliver McGowan training is right. I have no difficulty with it. I just have a problem with whether it will have the effect that it's intended to have. And I think if you don't change, put in the systems indicators to help you implement it, you know, but you won't know, you know, and that's why we need to evaluate it. We need a couple of hospitals that we can really make changes, but that's going to have some money. But given the amount of money you're going to spend anyway,
I think
a few million.
there is a program because it's gone out to tender at the moment for the longitudinal evaluation of Oliver McGowan.
Yes, and that was such a short turnaround of about 4 weeks and totally unrealistic of what they were asking to do, because I was going to put it in. That was just
And
crazy
there's the
to do.
accreditation as well. So
Yeah, it was a big ask.
So there is some money that's going
Yeah.
into that.
But this is why I think you need a long, because you're not going to see some of the impacts for about 10 years. So it has to be a longitudinal, at least 10 years, because if you're going to try and avoid death, it's going to take a few years to put those systems indicators in. You know what it's like to get policies in place, people in place, job descriptions, and then to get it working effectively. That's going to take a number of years.
We have one more question.
Oh yeah, thank you. Has NHS England engaged with this study?
This has been summarised in the Oliver McGowan pilot study. We did the report with Anna Marriott and her team, so this is all in it. They have the paper, and they have this summary in it.
So they have it, but have they engaged with it, as in, you know, giving it attention? Because I'm asking because the entire campaign, the legislation, the code of practice, the investment from NHS England has been entirely and only about the training.
Yeah.
And at the heart of everything we presented has been, I think what to all of us is the obvious fact that training alone won't change practice. So why are NHS England not engaging with that basic fact?
So I think that's the question for NHS England. I think
It
you
is.
should send them the PowerPoint, send them the
I'm
paper.
putting it rhetorically to the room.
Yeah, I agree. I think that's what you need to send them the paper. But that's in the Oliver McGowan pilot evaluation, and I think it's chapter 9 to talk about that chapter. This is all in it, except for the logic model. But all what I describe is in it. And we also said the training alone. We would worry that huge amount of money for 3 million people may not have the impact you intended to have. I think it's a good thing. I think it, like other awareness training, it will change people, maybe a bit of knowledge, a bit of attitudes, a bit of confidence. But will it really improve the care of people? Will we see a reduction in deaths?
I mean, I think it's even for the, it is a really good model when it works, but like you said, it's not even will it make a change. I think quite a few organizations are really struggling to get the resources to deliver the training in that model anyway.
Yeah.
Because of that,
Yeah.
like you said. So if you can do it, it's a good model.
And we've identified some of the systems, and there'll be other systems indicators as well, about what works. And we need to look at the literature to look at all those reasonable adjustments, But at that systems level, you need your learning disability champions, you need your acute liaison nurses, you need to be having your monitor. There's a lot of systems indicators that you can have, and then, but importantly, you need to measure outcomes to know what parts work, and then what parts don't, and then to try and then, if it's not working, step in very quickly. Because for so many times, interventions are allowed to be delivered, but we don't understand if they work. So Scott et al. In 2018 have come up with a logic model as well for implementing positive behaviour support and supported living in residential homes as well. I also saw people in the Netherlands have developed a logic model for delivering parental intervention. And if you are going to do an NIHR grant, you will not get it if you don't have a logic model, because that's the implementation strategy you need. And you will only ever get a logic model when you do the co-production. That you cannot do a logic model without the co-production, and it must start very, very early on in the process.
Go for it. We'll do one last question and then we'll wrap it up, just mindful of everyone's time.
So I've heard this all before about we're going to help people not to die, and we're going to help all this before. As I said, we've been around for 22 years and we're still talking about it. So unfortunately, it's like them scandals and secure settings. They'll say, oh yes, we're going to have a round table, we're going to talk about it, and they'll talk it out, and it happens again. And we want it happen again, and it happens again. Yeah, let's have a round table. But they talk about the same things again and again and again, and nothing's changing. And again, when they say we're going to stop this, never to happen again, it is going to happen. It doesn't matter how many times they have round tables, whatever you want to call it, until we sort out the social care, pay people proper wages, making sure they've got proper training, making sure they have everything done properly. It's still going to go on until I'm still living, really, because it's never going to change. As much as I say we're going to throw cash at social care, it's
like putting a stick in plaster on a problem.
So it's just, we still be here 20 years ago. What we're going to do, let's making sure people don't die in hospitals. How can we support people not die in hospitals, or how can we support people? It is still going to go on. Unless whatever they say, it is still going to go on. So yes, there's a mere.
Well, hopefully, if we take a different approach from a systems perspective, that hopefully will give a different lens of how to address the problem. A lot of times, sometimes in this field of learning disability, I don't think we take much of a systems approach, particularly when you look at the literature that's being published, with interventions, whether they work or not.
Right. Thank you so much, everybody, for your engagement. Thank you, Lawrence. It's been really interesting, and the conversation as well has been great. So thanks, everybody.
Thank you very much, everyone. It's nice talking to you. If anybody wants the PowerPoint, just give it to me.
If anybody wants the PowerPoint, feel free to shoot